So just remember that the recording here in the room, it just records the video footage of Dr. Yeoman and myself. It doesn't record the right-hand part of the screen where we can see people have joined and any questions that come in. And that's just to make sure it's a safe and private space. I'll give the questions verbally. So I'll get started on the questions that we've had sent in. But if you have any questions for us here in the room, just please put them in the chat and I'll pick them up from there. So first question we've got in today is, we currently have urso, oca, elfibranor, and also hopefully seladelpar in the not too distant future in the UK for slowing down the progression of PBC. Is there currently much progress though in investigation into CAR T cell therapy across the globe, which actually targets specific immune cells? And is this possibly more likely the way forward in treatments or trials going forward, perhaps in the next up to 10 years, to address the core issue of specific autoimmune diseases like PBC?
Yeah, it's a great question, isn't it? There's no specific studies for CAR T therapy. I mean, most of the studies at the moment are involved in sort of cancer therapies, and there are a couple of other studies in other autoimmune diseases, certainly the more common ones. So at the moment, there's no good evidence that these therapies change the behavior of PBC. But those sorts of very targeted therapies, as the person raising the question has rightly addressed, are much more specific to what the immune problem is in relation to PBC. So I think we're probably still some way off having enough core understanding of the specific drivers about what drives the damage to the liver and the bile ducts in PBC before we can get to the point of targeting those cell therapies. So it's something. It's certainly an area of huge interest for the future, but we're probably some way off it in autoimmune liver disease in general and PBC in specifics.
Great, thank you. Patient asking about gallbladder with 15% ejection fraction, no gallstones. What, if any, effect does that have on the liver?
It shouldn't have any direct effect on the liver. I mean, essentially what that's saying is that the gallbladder isn't contracting quite as efficiently as it should, even though it doesn't look obviously diseased. So we call that a dyskinetic or a poorly functioning gallbladder. Now, if people are having pain from that, sometimes they need to have their gallbladder removed, and sometimes having that scan result showing reduced gallbladder function can be a reason to take the gallbladder out. But if remembering the anatomy of the gallbladder sits just to the side of the liver, and the duct that drains the gallbladder joins the duct that drains from the liver. So actually, the gallbladder being a little bit dysfunctional shouldn't directly affect the liver and the liver's drainage at all. So from a PBC perspective, no major consequences. You wouldn't expect that to be associated with more abnormal liver tests, a faster progression of PBC or anything like that. But if people are having symptoms with a gallbladder that's not functioning quite as effectively as it should, then that's sometimes an indication for the surgeons to take it out. But that's a conversation between that person and their healthcare professional who's requested the test. But from a PBC perspective, I wouldn't worry.
Yeah, great, thank you. This next question does have some specifics in it, and I'll read through it, but I appreciate that what we'll have to do is try and generalise it for the answer. So, had PBC for over 3 years and managed well with little to no symptoms until about 3 months ago. Still an urso and liver enzymes are all normal. But the problem is terrible upper right quadrant pain that's under the rib cage that radiates around the back and up into shoulder blades, and the pain can last for days. Just had some investigation already done. Ultrasound and CT shows no gallstones or kidney stones. MRCP showed no stones or no structural issues noted, and there are further tests planned to see if there's any motility issues from gallbladder or sphincter or body. Food definitely sets it off, but no foods in particular, just eating or not. And they've had some hospital admissions due to the pain, but what they're being advised is that there's nothing else that can be found that's wrong, so that the pain is connected to PBC. Keen to get any thoughts on this, as the pain and discomfort is affecting every aspect of life. Is this level of pain normal with PBC?
Yeah, really sorry to hear this. It sounds like the person's really struggling with these symptoms. I think we wouldn't expect this degree of pain from PBC alone. We know that PBC is associated with other conditions. Some of those are autoimmune, as we know, but also people with PBC can get gallstones, and they can be hard to find sometimes on traditional scans, ultrasounds, MRI scans. Don't always pick up every single tiny bit of grit in either the bile duct or the gallbladder. So PBC itself shouldn't cause in itself significant pain. And that's the reason for that is that the liver itself has no nerve endings within it. So unless structures outside the liver down towards the large bile ducts, which PBC doesn't affect, PBC, remember, affects the very small bile ducts within the liver, then that shouldn't cause significant pain. Now, that's not to say that other effects, if you have Sjogren's syndrome, you have joint pains, or you can get fibromyalgia in association with PBC, and those can cause generalized pains, but those are not directly and specifically related to the PBC. So I don't think it's really, generally speaking, fair to say that PBC should be a ready explanation for significant pain, and it sounds like further investigations are ongoing to explore that possibility. Now, obviously that often leaves people in a difficult situation where, they're still stuck with the symptoms that they have. And very often we don't have all the answers, but from a purely biological standpoint, PBC shouldn't cause significant pain because it only affects the microscopic ducts, of which there's no nerve endings around there.
Great, thank you. On to our next question. Patient who wasn't responding to Urso alone, so was put on bezafibrate a year ago. The patient's 29. Should this be changed now that the new treatments are available and may be safer, or is it better to remain on bezafibrate? There's no mention about what our levels are at the moment, but just questioning if there's a possibility to change. Yeah,
it's a really good question, isn't it? And I think it's a question where there's not a definitive answer at this point in time, if I'm honest. So as the question alludes to, we now have 3 licensed therapies for PBC, whereas, when I started there was, it also wasn't licensed for it, but in terms of, treatments that we had available to use. So, so the key question here is this person responding? So at the liver test, has the ALP responded to the combination of the Urso and the bezafibrate? Because if they have, the rationale for change is less. Yeah. So bezafibrate is not licensed for PBC, but can be very effective, as we know from the Urso trial, and we know from clinical experience as well from using it. Like all medications, there will be potential side effects. So my general approach is, if somebody has met response criteria for their PBC with the medication that they're on, and they're not suffering from any complications of that therapy, then I wouldn't routinely make a change to a new medication, because realistically, if you respond to bezafibrate, you probably will respond to elafibranor, but might you get side effects from elafibranor that you've not had from bezafibrate? We don't really know. So I think it does come down to an individual discussion between the patient and their clinician, because at the moment there isn't a clear guidance on which the best thing to do is if you've responded. Now, if you haven't responded, it's an absolute no-brainer. You have to move forward into additional therapies. But if you have, then you've got to weigh up the pros and cons of, if you've responded well to a drug combination that you're tolerating well without any adverse effects, you may be better off than sticking with that, than making a change and then having a reaction to that new medication. And then you're having to sort of look for a different one again, and you've lost response and you're having to regain that response. So I think we're going to see this as a quite common question in these sessions, Mo. And there'll be questions about whether we should use elafibranor or seladelpar if people can't use obeticholic acid, and we don't have all the answers yet. And I think some of these things are going to take time to bed in and try to understand. And I think probably for the listeners and for people who catch up on these sorts of conversations, the reason why this is a challenge is that when drugs now get licensed, the problem is that the FDA drives this in the US, and all the other medicine regulatory agencies across the world use the same methodology. Is they will compare this new drug to placebo. So that's no other drug. So all we can say is that the new drug is better than giving you effectively a sugar pill. Yeah. What they don't tell us is whether the new drug is better than the old one. And many of us in the clinical space have been arguing for years, and I'm sure the foundation have it as well, is that what we want to see is that new drugs should be tested against the current standard of care.
Yeah.
So that means, in other words, people who are on URSO, if they haven't responded to URSO, or put them on URSO and elafibranor or seladelpar, and then to see how they respond. Because at the moment, it's very hard then to tell, when all these new drugs come out, is which one is better than the other, because they've only been tested against nothing. So yes, all the new therapies are better than giving you nothing, and they seem to be becoming increasingly more effective than giving nothing. So the response rates from the new therapies seem to be higher than the beta-cholic acid. They seem to be higher than with URSO for sure. But we don't know whether they're better than one another. So this will become, I think, a real circular question in these forums, and there isn't a straight answer. But it does all hinge on whether this person has responded to the medication first and foremost, and whether they have any adverse consequences of that medication. And if they have responded, no adverse consequences, I think it's entirely reasonable to stay on the bezafibrate. But if they haven't responded, then there's little doubt they should go on to different medications.
And try something else.
Because I think from that perspective, I don't know what's happening there, sorry. Because from that perspective, new therapies would definitely be indicated and would likely be effective for that person.
Great, thank you. Another question about bezafibrate. I know bezafibrate cannot be taken during pregnancy on both, as ALP was high on URSO alone. Are any of the two new drugs safe to be taken alongside? Does URSO keep ALP down during pregnancy? And any other general advice for navigating pregnancy with PBC?
Yeah, it's really difficult. None of the drugs are used in pregnancy, so we don't know is the problem. So, and actually, you're a very, 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 very small group of people to be have PBC and be pregnant. So it's very, very uncommon that it affects women of childbearing age. So so we don't have good evidence that they are safe during pregnancy. So I think URSO is safe to take during pregnancy, and we use URSO. URSO was originally developed as a medication to try and shrink gallstones, and also it's been used to treat intrahepatic cholestasis of pregnancy, which is a pregnancy-specific condition. So at the moment, URSO would be the only medication utilizable during pregnancy that we know to be safe. Now, what happens to your ALP in pregnancy is a really interesting thing, because we all think that the ALP only goes up because of bile duct and liver-related problems, but actually it can go up with bone problems. But also ALP is also produced by your placenta. So what will happen as a pregnancy progresses, particularly in what we call the third trimester or the last third of pregnancy, is that the placenta produces ALP. And so your ALP will undoubtedly go up in the final third of pregnancy, but not to be alarmed by that. That is entirely what we call physiological. That is normal placental function, and wouldn't be worried about that. So that puts things at a little bit of a hiatus, unfortunately, but we don't have other safe options to be able to utilize during pregnancy. So it will be URSO therapy, and then consider other options after successful delivery.
Great, thank you. Next question, how can portal hypertension be evaluated if one does not have a spleen?
That's a good question, isn't it? Yeah. So yeah, it's a brilliant question. So so portal hypertension, for those who are perhaps not so familiar with the terminology, is increased pressure in the portal vein. And the portal vein is formed by the splenic vein and the superior mesenteric vein, which comes from the gut. So one takes blood from the spleen, one takes blood from the gut, and those join to form the portal vein, and then they go into the liver. And when the liver becomes progressively more scarred, that puts pressure on that vein, and that's what we call like portal hypertension. Now, when that happens, if you have a spleen, very often the spleen will become enlarged. So if you see a spleen that's enlarged on a scan in the context of liver disease, you are suspicious. It doesn't confirm 100%, but you are then suspicious that that person has portal hypertension. There are some other ways you can assess for whether somebody has portal hypertension, though. And if somebody has cirrhosis, first and foremost, because you have to have cirrhosis before you develop portal hypertension. So portal hypertension is the next stage on from cirrhosis. Then sometimes you will have varices at the bottom of your esophagus, and sometimes those will be visible on CT scans. So you might sometimes even on ultrasound scans. So the presence of varices on a scan are a sign of portal hypertension. The presence of ascites or fluid in your abdominal cavity are also signs of portal hypertension. But those will only show it when the portal pressure is really quite high. So how would you look for less severe forms of portal hypertension? Well, there are some non-invasive ways we can do that. And the best way at the moment is probably via fibroscan. And there is some increasing evidence that fibroscans above a certain value can be associated with portal hypertension. So if your fibroscan is more than 20 and certain more than 25, the likelihood of you having portal hypertension is quite high. So it doesn't categorically prove it, but it suggests that you're at very high risk of having portal hypertension. Some centres now are able to do a spleen stiffness, obviously not applicable if somebody doesn't have a spleen. And the other thing that's starting to become a thing in certain centres is that sometimes you can do something called an endoscopic ultrasound guided portal pressure gradient. That's a bit of a mouthful, isn't it? Okay. What that actually means, if you break it down, is endoscopic ultrasound is an endoscopy with an ultrasound probe on it, and that can see the portal vein. It goes down into the intestine, and they can assess the portal vein. And then what they do is they pass a very small, fine needle through the intestine wall into the blood vessel, and you can directly measure the pressure. So you can directly measure, but that's not routinely available. It's not part of routine clinical care. But in some big academic centres across the UK, some people might have their portal pressure measured by that sort of technique. But there are a couple of ways to say presence of varices or ascites on scans, or presence of varices at an endoscopy, and also a fibroscan value can sometimes give you an indication of whether somebody's likely to have portal hypertension, even if they don't have a spleen any longer.
Great, thank you. What's the best way to manage hay fever when you have PBC? Are antihistamines safe to take? And if so, is there a particular type that's recommended? Really struggling with symptoms at the moment, but feel nervous about taking anything that might not be good for PBC. Yeah,
another really important and good question. I mean, the good news from this is that we've got lots of experience of using antihistamines in people who have PBC because they have some anti-itch properties. And if you look at our preliminary anti-itch therapies for PBC, a lot of those are antihistamine-based therapies. So from a PBC itch perspective, we tend to use the ones that are slightly sedating. I don't mean sort of, they don't knock you out, but they can make you feel a little bit woozy. So you have to be a little bit careful the first time you use them. Make sure you don't use them before driving or operating heavy machinery and things like that. But from a purely hay fever point of view, we know antihistamines are safe for you to take it in the vast majority of cases with liver disease. The one exception would be is if you have very, very advanced liver disease, where you're jaundiced or you've got liver failure, in which case you absolutely should seek advice from your healthcare professional. But for the vast majority of people living with PBC, an antihistamine would be safe to take, and any one of the ones you can get over the counter or from your GP would usually suffice for hay fever. So most of them will work equally effectively because hay fever tends to respond pretty well to antihistamines.
Great, thank you. Our next question is about urso weight gain. So again, there's a fair bit of detail. I'm going to read through it for you just for information, but again, I know that we need to generalise it in terms of the answer. So can urso cause weight gain, and does the dose of urso affect this, for example, if you were on the wrong dose? Personally, pre-diagnosis, I lost 3 stone in weight, and once taking urso, I've put 2 stone back on. I know myself this weight gain isn't all down to urso, as my level of activity is less due to other conditions. What I want to understand is, should I be taking 1200 milligrams per day of urso, but due to side effects, I only take 300? They are looking into whether or not elafibranor might be a good option as a secondary medication, but at the moment, the question is around, could the urso be to blame for this increase in weight? And if so, once the weight's gained, is that with them? Is that permanent?
Yeah. So we do see some people gain weight on urso. We certainly see it reported, and I think it doesn't tend to be very, very common, but it can occur. It's not usually huge weight gain. So if the weight gain is significant, it's less likely to be solely related to the medication, but it can. As the person asking the question has also raised, of course, there are often many other reasons which can be coexisting conditions with the PBC that can slow physical activity and make it harder. And of course, as we age, it becomes harder to maintain the same weight as when we were younger because our metabolism slows down. So there's lots of different things that can be at play with that. generally speaking, you tend to find that if a medication has been implicated in weight gain, it doesn't tend to sort of automatically fall off when people do change those medications, because the impact is probably fairly small. The one exception would probably be steroid therapy, of course. So people taking corticosteroids like prednisolone, those are very, very much associated with weight gain, and a lot of that weight will be lost quite quickly when the doses are reduced or the drug is stopped. So I wouldn't expect a significant reduction in weight by stopping it. So again, the broader question is, if you're on that medication and you're not at the full dose, is it then going to be effective for your condition? And if it's not, then second-line therapies are to be considered. And if there's an element of doubt of whether there's a drug reaction or a drug complication, for want of a better phrase, then sometimes we will sometimes give people a break from the ERSO to prove that that's the case. But obviously, you need to make sure that your PBC is appropriately managed with an alternative agent. So it sounds that that's being considered here, would seem to be appropriate, and that becomes particularly important if we haven't seen that response in the ALP level to the first line medication, which is ERSO.
Great, thank you. We've got a few more questions on the list here, 3 more that I'll run through, and then we've got a couple of questions that are coming in the room as well. But for anyone else in the room, we do have time for other questions today, so please pop your questions in and I'll pick that up once we've finished on our list. So, patient about to start on OCA at 5 milligrams daily as they've not responded well enough to ERSO. They're on 200 milligrams of pregabalin daily for nerve pain. The question is, will pregabalin help to combat the possible itch that a lot of people get from OCA?
Yeah, we don't know from the studies. I think we haven't got enough experience of enough people who've been on that combination to say whether it does dampen down or minimize the risk of significant itch. Significant itch only occurs in about 10-15% of patients, where you have to withdraw therapy. So, majority of people will tolerate it quite well. So at this point in time, we simply don't know. It's an interesting question as to whether pregabalin will modify that. But again, we don't routinely use pregabalin as an itch treatment. I know some people have used it, but the jury's still a little bit out on how effective that is at itch prevention. But what's this space, I suppose? And I think there's no reason why you can't have the combination. And the most important thing is that if you go on the medication and you manage it well, then great. But I think there's no data at the moment to be able to give us any more intelligence about whether you're likely to have less problems as a result of that drug combination.
Can we or should we take magnesium supplements to aid energy and sleep issues?
Yeah, good. I mean, I think so. Magnesium is a very interesting chemical, and certainly it can be associated with muscle fatigue. Do we check it in everybody all the time? No, we don't. I mean, there's usually specific reasons why magnesium levels go low. Magnesium supplementation isn't always the nicest stuff to take. It quite commonly causes diarrhea. And the reason for that, it's a metal salt, and what happens is it draws water into your intestine. So some of the over-the-counter preparations are very, very low levels, so very low concentrations of magnesium rather, so they're less likely to cause the effects than the sort of medical doses we would prescribe, but they still can cause diarrhea and unpleasant symptoms. So I think if you have symptoms that can be compatible with magnesium deficiency, and muscle pains can be one of those things, and your magnesium levels are low, then I think supplementation is appropriate. If not, I'm not a huge fan of using supplements without good evidence for their use, and it's always difficult to then tease out whether there's a placebo response or whether there's a coincidence response in terms of symptoms have improved just by chance. And some of these supplements can be quite expensive as well. So I'm always loath to recommend things for people which can be, because when you've got symptoms, you will always understandably want to have those symptoms resolved. But sometimes, you can spend a lot of money on things which aren't proven at all and can end up costing you a lot of money on an ongoing basis. And we don't want people to be losing their hard-earned cash to things which aren't a benefit. But certainly if you have muscle-associated symptoms, a magnesium level is reasonable to check, and if it's low, I would supplement. Otherwise, I wouldn't routinely.
Great. And the last question that we have on our list here is, can you take taurine with ERSO? I'm not familiar with taurine. Is that a supplement also?
Yeah, it's an amino acid supplement. There's no evidence that you can't. There's probably there's no suggestion that taurine is implicated in the pathology of PBC, or it's not going to help your PBC. But I don't think at this point in time that we've got any issues with those two interacting. So I don't see there being an issue with that.
Great, thank you. I'm going to move over to the questions that we've got in the room now. So our first one in the room is, have had acid reflux for many years, taking PPI for years. Does this have any correlation to my PBC?
Probably not. I think we don't see acid reflux as an autoimmune disorder. It is a mechanical condition, or it's a condition of excess acid production, which doesn't tend to have an autoimmune basis. In fact, one of the conditions that can affect the stomach, which is an autoimmune condition called pernicious anemia, can actually reduce acid production. So, sometimes if you have an associated gastric autoimmune condition, you're probably less likely to get acid reflux rather than more likely. So, there's no direct correlation. Acid reflux is extraordinarily common. About 40% of the population will have acid reflux at some point during their lives. And some people, it's one of the commonest reasons for presentation to your GP with acid heartburn and indigestion symptoms. So if you have a common condition, common conditions will commonly co-occur with rare conditions. So they just happen to have more than one thing.
Thank you. So our next question, currently being investigated for PBC, strongly positive for AMA and ANA and GGT and cholesterol raise, but my ALP is normal. Is it possible to have PBC with normal ALP, suffering severe fatigue, much more severe than with any other flares of autoimmune, have psoriasis, psoriatic arthritis and fibromyalgia for over 20 years?
Yeah, this is a not infrequent clinical conundrum, to be honest with you. We see this in our own clinics from time to time, and it's really challenging. So at the moment, the diagnostic criteria for PBC are to have an elevated AMA and an elevated ALP, or a biopsy that shows features of PBC. Now, the great challenge then becomes, if you have a normal ALP, is should you do a biopsy in somebody who has a completely normal ALP, because it could be entirely normal. So a normal ALP, even with a positive AMA, doesn't mean to say you have PBC now, but it means your lifetime risk of developing PBC is pretty high. So that's a conversation you'll need to have with your local team about what the relative merits are, because we don't like biopsying livers generally to make a diagnosis of PBC unless there's a strong suggestion. And if there is, if the ALP is completely normal, is there likely to be significant PBC? And we think probably unlikely to be significant PBC, but it's not to say that it can't be there at all. The challenge around the fatigue, of course, is that we know that fatigue is independent of the severity of liver disease. So the correlation between having an elevated AMA and significant fatigue, it could be that the fatigue is a manifestation of earlier PBC before you get the liver injury. The difficult bit around that, of course, is that treatment of PBC is to try and normalize the ALP. And if it's already normal, what are you going to be treating? And the challenge we have then is we don't have effective treatments for the fatigue associated. So this is why we don't tend to biopsy people who have AMA positivity and normal ALPs. What I tend to do personally is I tend to fibroscan people, because if their fibroscan is abnormal, then it's a different conversation about whether biopsy is justified or not. But at the same time, even if theoretically playing a thought experiment out, if somebody had a biopsy in this situation and it showed early stage PBC, would you start treatment? What is the end goal of treatment if your ALP is already normal? And also, whatever treatment we will be able to offer currently wouldn't impact on the symptomatology at the moment, which is the fatigue. So that's the tricky part. So if somebody has significant itching, that creates another challenge, because itching can be due to non-PBC reasons as well, of course. So we'll always want to explore cutaneous or dermatological reasons for itching. But certainly, again, you would go down the lines of using anti-itch therapies rather than a PBC-specific therapy, because we don't use any of the PBC targeted therapies just to manage itch, do we? We use, I know some of them have a slight benefit in the itch, but actually, when you look at itch management, we use other medications that don't actually impact on the ALP and the progression of the PBC. So I would say if you're struggling a lot with fatigue and there's there's other features there that could be driving that, even if you had early stage PBC, the management of the fatigue would not involve urso, it would not involve obeticholic acid or elafibranor or seladelpar. So there might be local services available to help manage chronic fatigue syndrome, because even though it doesn't automatically say you have chronic fatigue syndrome, the initial management is along exactly the same lines as those services that are set up for chronic fatigue or long COVID. So I know they're not specific to PBC and autoimmune disorders, but actually the services there and the best evidence base for how we can improve fatigue sits within those sorts of interventions. So it's probably best going down that line rather than into a liver biopsy.
No, that's great. Thank you. Just while we're talking about fatigue, there's just I think that the question that's just came in is in relation to that. Do you check blood calcium levels for any reason and potentially for fatigue?
Not routinely. I mean, obviously, a low calcium can affect muscle function as well. As can high calcium levels, but certainly low calcium can cause twitchy muscles and stuff. So generally with blood tests, there should always be a specific reason for doing the blood test. And so at the same time, there are sort of more commonly requested blood tests than others. So the most commonly requested blood test in primary care or in hospitals is a kidney function test. And the second most common is probably liver function tests. Those tend to get done. If you visit a doctor and you're having a blood test, you'll probably have one or two of those tests done. Calcium forms part of a different profile, so it's normally part of what we call the bone profile, because you're usually looking at bone disorders when you're requesting a calcium, although there might be other reasons for doing that. So, but they usually have to be requested specifically, and the GP or the hospital doctor will usually only request those if there's a specific problem, if there's a suggestion of a calcium disorder. So if people have got lots of muscle symptoms, then sometimes an extended panel, including checking calcium, is sometimes done, but it's not part of a routine panel of blood tests because it's quite uncommon for it to be abnormal without a specific reason.
Thank you. I've had conflicting advice regarding diet. When I asked my consultant, I was told no specific diet was necessary, but on having my recent fibroscan, the nurse said I should be on a low-fat diet. What are your thoughts on this, please?
Yeah, so this is a question I get asked in probably 8 out of 10 consultations around PBC. Alongside, is it anything I've done? What can I do to make it better? And I think because everybody wants to have agency or how they can help themselves, isn't it? The reality is that we don't have any evidence that any specific diet either promotes the development of PBC nor helps its symptoms. However, sometimes you can be given conflicting advice for the right intentions, and both people are right. And I'll explain why. So I think from the point of view of PBC, as I've already said, there's no evidence that diet neither causes it nor makes it better or worse once present. However, if you've had a fibroscan and that shows that you have a little bit of fatty change in your liver, then a low-fat diet might be recommended, or they might have recommended a low-fat diet in the absence of fat within the liver, just to prevent fatty liver from developing in the future. Because if fatty liver is coexistent with PBC, I'm not saying it will be, but in some cases, having two things that can upset the liver can accelerate the damage from either one of those conditions. So I suspect what sounds like happened there is that the advice has been given of either the finding of a slightly fatty liver, or that the people doing the fibroscan are using that opportunity to just give people good, sensible lifestyle advice around prevention of other things like a fatty liver that could exacerbate their PBC. Does that make sense?
Yes, it does. Yeah. That's all the questions that we've got in the room at the moment. So just the people that are here with us, if you have anything else, please just pop it in there. While we're waiting for some more questions, we've touched on fibroscans a fair bit today, and I just wanted to ask about this fibroscan score. Often people, when they're sending in their information for us for the Q&As, they'll include what the fibroscan score is, and we talk about it quite a lot. But I thought it might just be useful to go over what's a normal score when, and when the concern starts and as it gets higher.
Yeah. So fibroscan scores are different for different conditions. Okay, so they've been validated for different conditions. So if you have PBC causes a holdup of bile within your liver. We call that cholestasis. And if your liver has cholestasis, your liver tends to be stiff. So the liver actually gets more stiff in PBC than it does in some other conditions. So simple fatty liver disease, for example, doesn't tend to cause quite a stiff liver at a given degree of scar tissue compared to, say, PBC. So therefore, the thresholds are different. So that becomes important, because if people have had a family member who've had a fibroscan for fatty liver disease, for example, or for alcohol-related liver disease or hepatitis B, the thresholds are different. So that somebody might have been told it was normal at X value in a certain condition, and there will be a different threshold for PBC. So they don't automatically translate to one another. Nonetheless, we're usually looking for scan readings to be anything less than 8. We're pretty relaxed about in any cause, because that's not indicative of any significant liver damage. Really significant liver damage in PBC tends to occur above 15, and certainly cirrhosis is often 17, 18 plus. Whereas for some people with fatty liver disease, for example, they can have cirrhosis with FibroScan readings of 12. So that gives you an indication that's almost a 50% difference in the threshold for the different conditions. So that's, and Echosense, the company that produces FibroScan, there are other similar modalities that give you a liver stiffness measurement as well, or produce their validated scorecards, for want of a better phrase. And so that those can be used as a reference tool. But in general, anything above 15, you're certainly thinking of significant liver scarring there. Now, sometimes, again, you see it high to begin with, and after people have been on treatment, if the ALP falls, that reading can also improve. Because again, some of that FibroScan doesn't directly measure scar tissue. It uses the hardness of the liver as what we call a surrogate for damage. But if the liver is more cholestatic, it's got more bile holdup in it, but then you treat somebody with medication and they become less cholestatic and their ALP falls, then sometimes I have seen the FibroScans also fall with that. So I've seen somebody fairly recently who had a FibroScan of 10 to begin with, and you think, oh, that's on the way. And they've been on treatment for 2 or 3 years, and they responded really, really well, and their FibroScan's now 7. So sometimes I don't think that's all scar tissue improving. I think we've just improved the flow of bile through that liver, and that original FibroScan was measuring some of that. So really important that people don't overinterpret individual values. Have that contextualized by your healthcare professional. By all means, ask them about it. What does this test result mean for me? Is there anything else I need to do differently? It might be that the FibroScans also picked up there's some fatty change there that might warrant looking at a low-fat diet or some other interventions that way around. So it's really important to contextualize any single result. And the final thing to say about FibroScan is that, like all tests, it can sometimes be imperfect. And so we do see some people who have a one-off high FibroScan reading, and actually you think that doesn't quite fit together what we know about this person. And when you repeat it, it's much improved. And there are variabilities in test results, and sometimes things like if you've had a large meal before you've had your scan, that can put your FibroScan reading up a little bit more as well. So if somebody does have a one-off result, don't immediately panic. If it's elevated, have it explained and contextualized by your team, because it might be that they're going, yeah, actually that doesn't sit quite right to what we already know about you. We need to recheck that, or we need to do some other different tests to try and corroborate exactly how much scarring is there.
Great. And routinely, how often would you recommend FibroScans?
$1 billion question. We don't have robust data on that. We do need to gather that data. That will take probably some time. Now, obviously, the UK PBC guidelines are in the process of being re-looked at, and I'm sure that will be something that will be looked at as part of that guideline. Any recommendation will not be based on hard evidence. It'll be based on practicalities, I think. I think what most of us who have a real interest and see a lot of people with PBC would generally advocate for is using tools like FibroScan, and there's other tools as well. So there's blood tests called ELF that some people will use. I don't have a passion of which one's better than the other. Is that it's probably in the days where we don't biopsy people anymore, it's really helpful to not only look at the ALP to see how inflamed the liver is, for want of a better phrase, but actually how scarred it might be. So I think it's helpful. I think most patients should really have a FibroScan at some point if they haven't had a biopsy, or unless they're already known to have cirrhosis, in which case the FibroScan doesn't add very much for you. And then have it rechecked depending on how long somebody's had PBC and how abnormal or not the first one was. So, for example, if somebody's had PBC for 20 years and they've had their first FibroScan yesterday and it's completely normal and their ALP is normal, I probably wouldn't recheck it again. Because if you had the condition for 20 years and it's not damaged your liver, it's not going to suddenly damage it now when you're on treatment and you've responded well to that treatment. At the same time, if you've got somebody who's very young, very high ALP, we know that can sometimes be a risk factor for more rapid progression of PBC, and the fibroscan is 10, I'll probably be checking that in a year or so. If it's in the middle, if it's about 8, you might check it in 2 or 3 years. So the absolute intervals are not yet set in stone because we haven't done this in enough people yet to be able to corroborate and correlate that with clinical outcomes and clinical severity of their PBC. But I think the general principles are it's helpful to have one done, when I say at baseline, not necessarily immediately. I usually wait a year, just because you can see how people have responded to the medication. You get a bit of a true value for how much potential damage it is as opposed to inflammation. And then periodically, and it might be yearly, it might be 2 yearly, it might be 4 yearly, but actually in some people it might be never, because if they've got a normal scan after 20 odd years of having the condition, you're probably never going to develop problems that way around.
I know that when we do get questions in, sometimes it's different in different regions as well as to how often they might get one. Just to say that we're having our patient conference in September, and we're able to offer free fibroscan for patients again this year, which is great. We have a company coming in to provide those, which is really useful for people who have not been able to get access to them. So
yeah, absolutely. There's no doubt there's capacity issues. We've got lots of fibroscan machines where I work, but we still haven't caught up on probably fibroscan to everybody that we still care for PBC, because the tool became readily available long after they were already diagnosed. And some of those people have had a biopsy, and we know that their liver is entirely stable. So, and I don't want to send the message that absolutely everybody should have one, but certainly if you're a newly diagnosed with PBC, I think at some point in the early stages of that diagnosis, it's helpful. It provides additional information in staging. We have lots of risk tools which we use to try and identify who's at risk of developing more progressive problems with PBC. There's the PBC risk score is one of them, but that doesn't include fibroscan. And I think what we'll see in the next couple of years is that as more fibroscans are done, we'll be able to incorporate that and then say, well, if you have a fibroscan within the first year of diagnosis that is less than 8, for argument's sake, and your ALP normalizes on this, then your risk becomes much, much lower again. So I think this is very much an evolving field. But I think if you were offered a fibroscan, I would say definitely take it. It can provide additional useful information on the stage of your PBC in terms of the amount of damage that's there. And it can be used as a non-invasive way of monitoring your condition outside of just ALP. Because, it's ALP is important, but it's not the whole story. And so it can provide an additional way of monitoring your condition to make sure the condition isn't progressing.
Great, thank you. We're just approaching the end of time now. I'm just going to give people in the room a chance if they have any other questions. If not, someone's typing. If not, I was going to say I'll give you a little bit of time back, because I know you rushed home to be with us, and we've got some more of your time later this afternoon, Dr. Yeoman. I know at the foundation we've got another meeting booked in, which is fab. I'm just giving it a couple of minutes just to see if anyone else pops something in. I think one of the things that came out of and that's the meeting that we're in later on this afternoon, one of the things that came out of our PBC summit in April was about the importance of mental health around PBC as well. And we're really pleased to have you taking part in that conversation moving forward to see how we can help with that. It was very much heard loud and clear at the summit from the patient representatives that were there from around the world. So it's really good to see that start to move. Yeah,
so we've got a couple of minutes. I may as well probably tell people who are perhaps not so familiar with that. At the summit this year, I think, did I volunteer or was I volunteered? I can't remember which one it was.
Probably a bit of both.
Probably a problem was involved. I was probably nudged in the general direction. But no, I think it was very, very clear. So each time at the summit, we always try to pick 3 major topics and themes that come through, because the summit's a really powerful couple of days. It's one of the most enjoyable things I certainly attend every single year, in terms of really bringing that challenge that patients experience all that time into how we change what we do as a clinical community, and again working with pharmaceutical industry and other third sectors and other partners. So mental health was a really important that came out. It's always been important, of course it has, but it was a really strong theme this year. And so what we wanted to do is try to bring a group or working party, I guess, together to try to think about how we might improve that. So what we're working at the moment is looking at trying to develop some tools to assist or support self-management within these things, but also to help open up a conversation with local healthcare professionals, and also produce a toolkit for healthcare professionals, highlighting to them the importance of mental health aspects. Now, I'll hold my hands up. I had no mental health training during my, medical training other than at undergraduate level. And it's still very appropriate that people have appropriate input, sometimes from GP, sometimes from a local mental health team, or clinical psychologists if you're lucky enough to have access to those. But what we're trying to do here is trying to sort of really reinforce the clinicians who look after people with PBC, just that hidden burden, I think, of the mental harms and the psychological harms that people often experience living with a chronic condition that doesn't have a cure, that doesn't have perfect medical therapy. And some of the symptoms have very poor therapy, fatigue being the obvious one. Yeah. So we're looking at different resources out at the minute. What can we adopt that would work across PBC? What needs to be tweaked to be more PBC specific? How we can develop that's appropriate for different jurisdictions across the world, different countries, language barriers, cultural barriers, all those sorts of things. Yeah. And then try to see if we can produce a couple of resources that would be utilizable for all you good people, to see if we can help people feel more supported and give them tips and tools and tricks and guidance on how to have a better psychological health when you're living with a chronic condition. Because we know we can't fix everything, but actually sometimes the acknowledgement, validation, but also that there may well be signposting to different services people are not aware of that can help them manage. So I wasn't aware locally, for example, that our long COVID and chronic fatigue service, you don't have to have a formal diagnosis of those conditions to self-refer into those if you're struggling. Yeah. Mm-hmm. So sometimes it opens up, people go, oh, I wasn't aware of that. So sometimes we're not always aware of what's around us and what our patients might be able to avail themselves of. So I think it's about trying to signpost where appropriate. So any resource we produce will probably be modified. We'll produce it in a rough template form and then modified for different jurisdictions, so that local people in different countries can add their own little bit of, well, in Poland we have something like this, or in the US we have something like this, or so that people can have the most relevant information for their locality. But at the same time, the key principle is provide some really solid clinical evidence-based with patient input about some tools that can really help people manage these psychological harms.
And that's the benefit of the summit, isn't it, in terms of bringing together the international community so that we can make sure that we're addressing it for each of the areas. There's just a question that popped in there in reference when we were talking about the fibroscans at the conference, and somebody asking if there's a really terrible result from the fibroscan, will you tell us or filter it somehow? And just to say that there are healthcare professionals at the conference who will be delivering that. We also have a nurse on staff at the foundation now as well, so there will be people there, and obviously we'll be there as a team as well if there's anything, because we do realise that can have an impact on people as well if they receive news they weren't expecting as a result of a test. But the test results will be explained to you by the healthcare professional that's doing the scan there. I'm going to sneak in one question just because it's in the room before I let you go, Dr. Yeoman, and it's, can low ferritin have any relation to PBC?
Low ferritin is usually a sign that you're lacking in iron. So if you have a low ferritin, you nearly always need some iron therapy, but you might need some investigations as to why you're iron deficient. It's not usually directly related to PBC. Iron deficiency is quite a common thing in the general population. It doesn't always require investigation if you're a premenopausal woman, because menstruation itself can just be, but certainly if your ferritin is low, have a conversation with your GP or whoever's requested that test about whether you do need additional investigations or whether you need iron replacement therapy. But there's no suggestion that it will either have any impact on your PBC negatively or positively, and it's not directly related. So iron deficiency is not an autoimmune disorder per se. It's just something that happens quite frequently. Great.
Thank you. Thank you so much for joining us today. I'm just going to wrap up there, and just to say that. No, that's okay. That's okay. We really do appreciate you taking your time out. And just the people who are joining us or perhaps watching on catch up as well, just remember that we're here on the helpline if anyone needs support, just to get back in touch with us. And any questions can be submitted for future sessions on our online contact form on the website. We are back again next week, but it's Dr. Weltman from Sydney who's back with us next week, so keep an eye out for the time. It'll likely be around 4 p.m. Sydney time, which is 7 a.m. UK time. I try and keep them not too early, so it's getting to 3 and 4 a.m. for me. That's a bit of a push, so we'll just be finalising that and getting that out, so look out for that. But thank you so much, Dr. Yeoman, and we'll see you again soon.
Yep, see you later, Mo. Okay.
Take care. Bye.
Bye now.